Good morning, ladies and gentlemen. My name is Félix Wucherpfennig Price. I am from Malaga, Spain, and I am here today to talk about how reliable Zirconia monolithic could be in full X. Okay, I work in Crucal Laguna, and I am part of the implant department. In the last few years, over the last decade, I've been working in Spain and in the UK. Okay, and mainly I was delivering full arches cases. So if I live in Spain and I go once a month to the UK, I had to make sure that I was delivering a nice treatment. Why? Because I cannot have many complications into the teeth. Before, 10 years ago, we used to do metal ceramic, metal resin teeth, but a lot of problems after 4 or 5 years, chipping, fractures of the teeth. So then the Zirconia monolithic came, and most we're using a lot to deliver this because the material is really strong. So when we do a full arch case, the initial checkup is obviously very important, okay? Because if we have a mistake in this accurate checkup, then we can end up with more problems, okay? So it's very important to have that in mind. The complex surgery, nowadays we have the implant system, which makes our life easier, but still an implant surgery, and it's a multiple implant placement, and it is quite complex. So not everybody can do that. So you need to have a learned curve. Functionality recovery of the patient, okay? The patient, some of them, they've been to over 20 years without any teeth. So it's a challenge to have fixed teeth again and make sure that they are able to eat and chew. And the high aesthetic demands, okay? The patients, they really come to us for teeth, okay? They don't really care about how nice the implants are. It's just they want to be confident to go outside and socialize, okay? So the aesthetics is really high. So from 2017, I have taken 123 arches done by myself, and they've been done fully digital, okay, with the same lab. And what I want to show today, to share with you guys, is the fractures that I had, why I had those fractures, and how I've been solving them, okay? We know that zirconia is a really strong material, but it doesn't have flexibility. So people that they don't use zirconia, colleagues, they are really scared of using that. And I agree with them. But if you have the right technician using the zirconia and doing the proper analysis on the zirconia structure, we can have really strong and reliable results. On the first year, I wasn't really familiar. In 2017, I wasn't really familiar with the system, okay? Because in 2016, we got the first intraoral scanners, and we started with a couple of crowns, and then we went bigger ourselves and the lab that we use, okay? So the first year, I had 4 fractures, and that was the most of the fractures that I had, and I will tell you how we've been solving them. And when the time goes, 2020 was COVID, so more patients were with temporaries, and we didn't have any, and we have reduced this to none at the moment. Maybe we'll have more in the future, I don't know. But what I can say is that all the fracture happened on the first date because of the tension, or the first month, the first 6 months, I would say, okay? I haven't had a case where after 2 years, the zirconia comes in 2 pieces, okay, so far. And I wanted to know who was the fault, okay, why those fractures happened. 44% cases of those fractures, of those 9 fractures, the 44% of them were because of the technician who designed. Because sometimes to try to individualize the teeth, to make them more natural, you make the structure weaker, okay? So the fracture happened into there, especially in the middle line, okay? And the other 44% was my fault, because sometimes after 3 months, we tightened up the multi-unit abutment, and we changed slightly the position of the multi-unit. So with the temporaries, which is done on PMMA, you don't feel it, but they can, when you fit the zirconia teeth, you can create some tension, and the tension it will lead into a broken teeth. Okay, so make sure that you don't change the position of the or modify the height of the multi-units, because even 0.5 millimeter, it will make a difference and it will break. And there is another 22% chance that we don't really know what happened. They believe sometimes the temperature, the cool area of the room. We are not sure yet, but we are analyzing that. So in all the cases, what we have done is a protocol. We call it 3-step smiles. Okay. In the first step, we take photos, STL, and a CBCT. We combine everything and we do the project for the patient. Then we have the surgery delivery, and the patient go home with no teeth. And during the night, we do a milling machine, PMMA teeth, and we load the teeth the next day. 3 months later, the patient come back, and we decided some changes. We scan the bite again, and we order the Zirconia teeth. Then this is our case for today. His name is Miguel, 55-year-old, heavy smoker, advanced periodontal disease, mobility, patient cannot chew. And I asked him, Plus, I need some photos. Give me a big smile. This is Miguel's smile. So not right. So I said, okay, Miguel, let's go deep enough into your smile. It's still not really high smile, but at least it's something that I can work with. Start to do some design before we start with the surgery. This is the STL from the patient. We see really periodontal advanced disease. And make sure if you're going to do a surgical guide that you can collect most of the information that you can get and the teeth in order to have the fitting. If the STL is not right, the fitting of the guide for the surgery can be wrong, and then you can have wrong position implants. Same thing happened at the bottom. Situation not the best, but this is a nice STL that we can use. And the CBCT, then we find more surprises, defects, infections, and we said, okay, Miguel, it's a big challenge. You have enough bone underneath. We will do in the spaces that we have, we do some grafts in order to recover some areas, okay? But let's see what we can do for you. Same thing happened at the bottom, but the good thing is that the bone condition was better. So I was quite optimistic about his case. Then we send this to the lab. The lab make the design, and we keep the vertical dimension. This is very important. We don't want to change the patient vertical dimension, the height, okay? We want him to be comfortable. But I want to see these teeth into the patient mouth, okay? So what I do, I ask my lab to do this design, and thanks to digital dentistry, we can see the patient's teeth into the mouth, and then we can tell him that we're going to rectify the overbite, that we're going to solve his problem, but this is all before we touch him, okay? So once he agreed to this and the patient is motivated, then we say, okay, let's do the plan, okay? When we're going to place the implant, as Gallucci says in 2022, if you don't place right the position of the implant, you can lead with a problem designing the teeth, okay? So if the apicocoronal position of the implant is not right, if the implant is not deep enough, then you're going to end up doing a really thick crown. So that can cause you a problem, hygienic points, and leading to peri-implantitis. If, for example, the mesiodistal distance between implant and teeth, it has to be 1.5 millimeter from one tooth to one implant, and between two implants, it has to be 3 millimeters. But the most crucial part for me is in anterior area. Sometimes the maxillary is too, it forces us to angulate the implants a lot, and you can end up with this problem. So this is a problem, it's a failure from us. So if we know that we can have these problems, use a guide. If it's simple procedure. And if we do surgical guided surgeries, we can end up having teeth like on the left side. And I don't want to have teeth like on the right side of the image, because at the end of the day, this could cause problems to the patient collecting food, peri-implantitis, and a treatment failure, basically. At the same time, zirconia, as we said, is very strong, but it's not flexible. So we cannot deliver non-parallel implants. We have to deliver parallel implants, okay? Make our life easier and for the lab as well. So for this reason, I use Artugate for the last 3 years, and I'm really happy and satisfied with my results and implant positions. At the same time, I decided to ask to my lab, okay, I want to have the design of Miguel into my project. Why? Because I want to guide my implants with Miguel's final teeth, okay? So before, we used to place all the implants and then decide where to place the teeth. This is the other way around nowadays. We can place the teeth of Miguel and see where we want to have the teeth and the implant position, okay? And at the same time, at the top, we did tilted implant in the back using angulated multi-unit abutments in order to avoid the sinus lift. The same thing happened at the bottom. We remove the teeth that we don't want for the surgery. Those teeth are left for the fitting of the surgical guide, and we make sure that we don't damage any nerve, okay? But at the same time, we have the project of the teeth, and we can guide the implant through the teeth. Once we have done, we can check in every single implant the length of the multi-unit abutment that we want to use. If we are not invading other areas, and we are leaving enough bone outside, inside, okay, to make sure that we have a long-term treatment, okay? If the implants are really, they are not right placed, then we can have gum loss, bone loss, and periimplantitis or problems. Same thing happened at the bottom, and then we go for the surgery and provisionals, okay? This is the model that I left for the top in order to design the surgical guide. And this is my top surgical guide. Make sure the surgical guide is thick enough to not have fractures into that, okay? And once that is done, then the bottom as well, we decided to leave the canines and the molar, okay, in order to design the surgical guide. And this is the surgical guide designed for the bottom. Again, thick enough to not have fractures of the guide. Then we go to the placement, and then we place every single implant that we do is fully guided, okay, to make sure that what we promised to Miguel is it happens. Okay, at the same time, every time that we drill, and the good thing is with we use any rich implant system, and the good thing is that we collect a lot of bone from the patient, and then we mix it with the PREF from the patient, and we create a sticky bone. So every tooth that we remove from the surgery, or any gap that we have between implant and bone, we fill with the sticky bone in order to keep and maintain the volume. Then this is the patient after the surgery, minimum invasive surgery, and this is what we should have as an STL, okay? Hardly any stitch, and non-invasive treatment, and an STL where the patient, the lab can work with this. Same thing happened at the bottom. We leave some teeth because this is very useful for the lab to join the previous STL model with this one and have a good bite record. So after that we have all that, then it goes to the protocol. We work with the dental lab, it's called Dental Aesthetic, and they have a protocol which is called medical fit. When we take an intraoral scanner after a surgery, we will have a deviation for sure. If there is no teeth, we will have a deviation, okay? So what they have done is in every single surgery that we do, we put the scan bodies, take an intraoral scanner, and we have to do a CBCT in order to rectify this error. We can have up to 2 millimeters error into the fitting. So it's not valid to finish an all-on-6, do an intraoral scanner, and send it to the lab. We need to rectify the error with something. In this case, with Medical Fit 1, we rectify this error in order to have a passive structure. If for any reason you don't want to do another X-ray to the patient, or the X-ray is not right, what they have done is a tray, which is called Medical Fit 2, and what you do is just a pickup. And once you do the pickup, you just use your intraoral scanner and you send it again, the STL with this, and then you can rectify the position of the implant again and rectify the error from the intraoral scanner. At the same time as well, we have some problems, okay? Because when we used to do, especially in the temporaries, the T-base used to get uncemented, okay? So what they had is they told us, look, Felix, if we leave this base, it's gonna be very breakable, okay? It's not deep enough to not break, okay? So what they have decided is that they increase the base of the multi-unit design and making a longer screw from 0.6 to 1.1, okay? So like this, we can work direct to the multi-unit connection, and we will have non-uncemented problems. So this is the design, the analysis of the weakness of a non-modified multi-unit base, okay? So it will break if we don't do anything. If we work like this, it will break through the connection. But if once it's been modified, you release the tension up to 6 times. Okay, so like this, there is no need of T-base. Any fracture that I showed you before never happened into the connection. It always happened into the middle line because of the tension. So we release the tension. Then we have Miguel's teeth, and then we make sure the engineer check that the design is strong enough. Blue areas, that's what you want, okay? Top area on the left side, on the area 26, we said, look, there is a weak point where you can see some green light. So they modified the zirconia in there to make it blue. Okay, the same thing happened at the bottom into the area 46. It was too weak, so they designed it. So this is how you check that the zirconia cannot break, okay, or shouldn't break. Then we can have a milling machine, ultra polish, PMMA as a temporary, okay, and no T-base use again. Like this, we won't have problems with that. So if for the patient have lost a lot of bone, we will do a type 2 type of teeth using PEEK zirconia or titanium zirconia Or if the patient has too much teeth, then you can have a type 1 with a direct zirconia over the gum line. All this is not just saying this. It's been studied through many articles about this protocol. They are there in literature, so you can check with that. And this is Miguel after 12 weeks, after 3 months smoking every day, and that's how the PMMA showed to me like this. So I was really scared of what was going to happen. I said, "Look, Miguel, you didn't take care of yourself, okay? But look how the gum looked, okay? If the implants were placed, positioned, he was lucky with his biotype, okay? And this is what you want to see in every case. This is what you want to see. Stabilize gums and tissues, okay? We have rectified the problems. The same thing happened at the bottom, okay? After 12 weeks. And the final smile, a proper bite with the problem that sorted, okay? This is what you want. And what you want is a patient really happy and satisfied with that, okay? So at the end of the day, this is after a year, and you want to see bone level, everything nice and simple. This is a long-term treatment solution, okay? So zirconia is a reliable material for me. When you place the implant parallel position, you release the tension, but you need to work with a lab that is specialized in that, okay? And I just want to share this message to every patient and to every dentist, okay? Plan your cases, design, and do it, okay? So just guide it, just do your plan, and just guide it and do your implant.